Okay, so in a few slides, I just want to explain for the people who have not received the questionnaire what we have done. The principle of the study was to write the first guidance for the management of joint deformities of adult patients with central neurologic system lesion and muscle hypertonia by integrating the medical dimension, surgery, and physiotherapy. So it was the first time that we tried to work all together and to create a questionnaire. It was obviously, you saw it this morning, very, very difficult. We tried to work on two deformities, equinevarus foot and the elbow flexion. So we tried to build a questionnaire with different experts, and it was really, really a big job, and it was really tougher than we thought. So obviously, sometimes we have forgotten some way of thinking of maybe neurosurgeon, maybe plastic surgeon, and that stuff. That's not so easy. It was, the questionnaire was about, the first questionnaire was about 246 questions. So it was about 1 hour and a half just to fill it. And so it was very, very difficult, and we need to criticize it, but at the end, the aim is to publish one paper from all this community and to show that we are beginning, working together, trying to find some consensus between all these disciplines. So thank you for these experts who work with me and to criticize the questionnaire each time, and voilà. So the procedure was to elaborate the criteria for the selection of experts. At the beginning, the principle is to find some experts, and this was performed by the steering committee. So the criteria was to belong one of the following disciplines, so physical medicine and rehabilitation, orthopedic surgery, neurosurgery, etc. To have published of one of the two subjects, elbow and equinevarus foot, during the last 10 years, or to be recognized as one of the experts team in the field for 10 years. After we have created the list of potential experts, and we contacted them, sending an invitation. It was not really an explanation, it was an explanation. And after, we invited this expert to participate to the study. It was at about 54 or 50, it depends on the question. So there has been the administration of the questionnaire, and after there is several rounds. So the first questionnaire was about, I told you a lot of questions, and we need to have at least 18, so we have more than 18, so that's correct. And after, we have to make a meeting with a methodology company. Fortunately, it was in Canada, as we work by night, so with the jet lag, it was in a good, good sense of the jet lag. And we make the summary of all the response, we classify the answers, and there is some consensus sometimes. More than 80% of the respondents have said the same thing. Or there is lack of consensus, and for this we have to determine if it was due to the difference of opinion or due to a lack of scientific data. And with this, we have to rebuild a second round and to send to the same experts. They have to fill it, and after, like this, we can make, I don't know if you want 20 rounds, but we decided to make 2 rounds. But after 2 rounds, there were some lack of consensus of measure questions, and so we need to make a 3rd round just to increase, for the methodology aspect for the publication, to have a 3rd round. That's why the expert has to fill it during this Congress, the 10 last questions before you. So today, you are going, at the end, we have to write, there will be a quality questionnaire, and after we have to write and publicate the guidance, not really the recommendation. And probably during the Sophomore Congress, we are going to present a part of the results. I think there will be a huge job after this meeting to organize all this data, because we have a lot of data, quantitative and qualitative data. So today, you are going to see the response, the consensus, with a huge job from Laure Gatin and Marjorie Salga, who made all the analysis with me and made all the calculation with that stuff with the methodological company and the statistician. And sometimes there will be some question. And for this, you have this device, and you have to respond to the question. It's exactly the delphi 3, the third round, that the expert has already responded. The expert has to respond also during this round, okay? So, as you see on the little box, you have several choices, 1, 2, 3, 4, 5, okay? There is some question with only one answer. Sometimes you can select 1, 2, or 3, okay? At the end, you have to validate pushing on the OK button. And if you want to be sure that then you have done OK, it's written on the top of the screen here, OK. Okay? You have 30 seconds to respond to the question, and there will be, a timer here to respond to the question. At the end, we see the bar and the response of the community. Okay? All this data is going back in an Excel sheet, and we are going to add this response, not in the delphi 2 or the experts, but during the discussion, we can say that we have a big meeting with a huge expert team, and maybe we find some better consensus on this question. So we are not going to make all the questions, we are just going to talk about the specific questions that, for that there was no consensus. Okay? That's correct? Okay, so I think that's it. So now it's your turn. Alors, we have to change the laptop because it's a specific program for this. So the 24 experts for the elbow flexion have to work during lunch. There will be one laptop on the table. So only 10 questions, it's about 4 minutes just to respond to the question. So there are some experts here, you have to go.
Okay. Thank you. So, like in award ceremony, there is results, and it's the results of the Delphi panel. And my dear colleague Marjorie Salga will be the mistress of ceremony to show you the results.
Yeah, so I'm not going to present all the 110 questions results, and you'll see. So we decided to present the results, but also to integrate the questions that you're going to answer to in the talk. So it's going to be less boring for you and more interactive. So yeah, Delphi 1 was 110 questions. The questionnaire had been sent to 50 experts, and we got 24 answers. Most people were PMR physicians, but also a lot of surgeons. So we got 90 consensus. Okay, it doesn't. Okay. And Delphi 2, so the second questionnaire was only 37 questions. We got 22 answers. And the third questionnaire was 14 questions with 22 answers. And when we couldn't find any consensus, we did some new questions, and we are going to answer all together today. So first, when a patient arrives in consultation, move on. We try to determine which muscle is involved in the deformity. For equinevarus, people were agreed to say that the most common muscle is tibialis posterior, but 3 other muscles were also important, but not a consensus. The first one is the tibialis anterior, the second one gastrocnemius medialis, and the third one was the soleus. For the hindfoot equinus, no consensus. about muscle involved in the deformity, but three important muscles: the soleus, gastrocnemius medialis, and gastrocnemius lateralis. For the forefoot pronation, so we got some questions about maybe we could have put a picture in the questionnaire because maybe it was not clear. So sorry for that, but no consensus again. But two muscles important for the experts. It was the fibularis longus and abductor hallucis. And all the experts were agreed to say that pronator muscles of the forefoot indirectly induce varus of the hindfoot. So everything which is written in red is a consensus. All the experts were also agreed to say that functional muscle activation is more important to assess function than analytic muscle activation. And before the surgery, experts were saying that it's important to differentiate muscle overactivity from retractions, and we have to assess co-contraction and muscle overactivity of antagonist muscles. To assess equinevarus foot deformity, we should use motor nerve blocks to assess deformity. We can do nerve blocks on total or selective tibial nerve blocks. And we use local anesthetic. So that's a consensus. The second one is using another tool we can use. It's 2D video analysis and quantitative analysis of movement, gut analysis. And experts were saying that we use that more for complex situations, like multi-level deformities, when we have to assess patient before and after treatment, and also to fill out data in a database, for instance. And another very important tool was imaging before any treatment. X-ray and CT scan, we were all agreeing with that, but what for? And you're going to answer. So that's the first question we ask you. I need the remote. The first question is, so you all have your electronic box. The first question is, does a radiological exam could be needed before surgery to assess, so number one, quality of joint surfaces, number two, understand the mechanism of the deformity, deformation, correctibly joints involved in a deformity, and three, maybe other answers.
So wait a minute.
So you have to wait. Yeah, now you can go.
You can vote.
No,
press OK at the end.
Yeah, don't forget to press OK.
We are going to check. Okay. So that's the first answers of. So it's about 55. I don't know how many devices we have in the room. So there is an equilibration between the two first questions, and I think that's maybe a little bit specific to equinevarus foot, because for the elbow you will see that it's a little bit different. Is there any question, or you want to say something about that? No? This question, that's okay? We're going to have a discussion at the end, but if you want just to, okay, follow up.
Okay, so there is another question about electroneuromyography, because experts were not totally agree with the indication, or do we have to do yes or not? So we have another question for that. So is performing electroneuromyography before surgery important to assess equinevarus foot deformity? So it's written very tiny, so I'm going to read it for you. So the first question is, the first answer is, in order to evaluate the activity of agonist muscles implicated in equinevarus foot deformity during rest. The second is exactly the same answer, but during muscle contraction. The number three is, we can start it again.
I need an expert.
Well, number 3, so evaluate the antagonist muscles implicated in equinevarus foot deformation during rest, and the fourth answer is the same one, but during muscle contractions.
We have Salim Boutaleb from Malagan, who is the expert on the media vote. Paul vote, no. Back, Boach. Don't worry, it will work. Think about the question. Thinking very, very hardly. You mean dynamic imaging? Yes. Don't press the button. Okay.
Ok.
C'est pas la bonne
Il faut
slide.
aller sur
Encore une. Yep.
Ok.
Don't worry. So, are you ready?
Yeah, and the fifth answer is it's not important.
Yes, if you think it's not important, you have to press 5. Go.
Yeah, in general, during the movement.
That's a question, yeah. That's a good question. Maybe
But
you
we can debate.
You want to say something? The question is that during the gait? I think it's very important for you to differentiate during the gait or not. Okay. It should be during the gait. It should be? That the question, that's a remark from... I know, but that's not what it says. Yes, that's okay. I totally agree. That's why maybe this question is not really, well, you know, and maybe we have to change it a little bit. What do you think of that? It's during the gait? You want to? Okay? Everybody's okay? So maybe you have to go back. Thank you, Salim. And we are going to make it one more time.
Francois, but then the answers don't match because it says during rest.
Yes, of course.
Twice.
So, okay.
So it's not a good answer to match the question.
Okay.
Or not a good question.
That's true.
At all.
Okay. So,
2, 4, or 5.
2, 4, or 5. Yes, that's why. So we skip this question now. Okay? Perfect. We'll pass. No, that's correct.
No,
that's why, you know.
We are doing that to talk about the
and
question, so it's perfect.
A headache after each question, so if you have to. So you can through.
Okay, so next. But we can still notice that there is few people that are not using it at all. So other question, is there a relation between electroneuromyography signal and strength developed by muscle overactivity?
Before voting, everyone is okay about this question. Is there any remarks? That's okay? Wait, we're waiting. You have to wait that the timer is going on. And happy to see that Salim has a problem also. That was not me. Again. the problem is that the question we wanted to ask is, you know, when you want to assess the antagonist muscles on deformity or before a transfer, is electromyography is a good tool to assess the strength, or just it's a new tool to a predictive tool for the surgery? That's a little bit, that was the question, but that's true. But how do you ask this question? Yes, but when you make some transfer in spastic patient, very, very often it's you exploit the overactivity. And so it's the strength developed by the overactivity. That's not so, how to ask this question? It's very, very difficult, if you have an idea. Sorry, you have to use this because for the translator.
When I read the question, my opinion is that you ask me to say at rest, if you have an activity at rest, is it muscle overactivity or it's not muscle overactivity? That's my interpretation of the question.
No, I interpret it completely different. Here the question is, can you use electromyography intensity, measuring the electromyography as a way to measure strength? That's how I see it.
That's exactly
And
what I wanted to do.
That's the question?
Yes.
So I think that the correct way to ask the question would be something like you've placed there, which is there a relationship between electromyographic activity and the strength? I want to answer.
That's okay for everyone? Maybe Franco?
But again, you are looking the patient during stretching or during gait. Then we have to define, is overactivity due to stretch?
The question is, can you use EMG as a measure of strength? That's the question. Answer yes or
This
no.
is another long story in terms of
Answer
neurophysiology
yes or no.
relationship between
That's the
EMG and power of the muscle.
So, you can go. We are following. So, the question of Alberto. It does not work. That's not possible. Even it doesn't matter. We have a lot of discussion. That's correct. So,
You can always use the old method.
yeah, yeah. So, technology works. So, okay. Well, the debate. So, is someone wants to respond to this question? So, is there any relationship? For me, no. For me, it's really, really a bad way for the assessment. We need to use electromyography, but not for that. Are you agree with that?
So just, I think the way to answer the question is, how many hands for yes? One, very good. How many hands for no? There is your answer.
I think I had to recruit Alberto for the method at the beginning of this story, you know. It would so, you want to add something?
It's not a linear, it's not a clear relation, but there is some degree of relation between the electric activity in electromyography and strength. I think it's probably not clinically relevant. I agree with you. But on fundamental point of view, there is a relation. You can make some works and have an idea of, but it's not really to use and to convert in clinical advice.
Yes, you are right, but it's unpredictable.
Okay, so we can go. Marjorie.
Maybe you can pass this one.
Next one. No, in the other way. Okay, next one. Slide. No.
Okay.
I am very tired.
The answer to that one is yes.
Yes.
So then next question of Professor Genêt will be, how am I going to treat this patient? So regarding medical treatment, when the patient have a fully correctable equinevarus deformation, the experts are saying that we should first have no surgical option, no surgical treatment, and we should prescribe or propose physical therapy, such as stretching, and use botulinum toxin injections, which is logic. For partially and uncorrectable deformities, surgery, we can propose surgery, but there is no consensus. It depends on patients. But physical therapy and botulinum toxin injections are consensus to be part of the treatment for these patients. And for oral baclofen to treat muscle overactivity, experts are all agree to say that there is no indication if we are in fully correctable or no correctable deformities. Next slide. Now, if we think about going to surgery, what could be helpful for the physician to propose surgery? The patient could be seen by a PMR, because they are not always seen by a PMR, so this is a consensus. Also interesting before to propose surgery, it's regarding the outcome of repetitive botulinum toxin injections, patient's motivation and autonomy, and also the type of muscle overactivity. So all of these characteristics are important to decide if we go yes or no to surgery. And surgery, it's possible within 1 year after central nervous system damage.
Any reaction? This? That's okay for everyone? Okay. Up.
I'm very happy to see that the type of muscle overactivity is mentioned as healthy.
Yeah, yeah, yes. We had this discussion because, yes, it was a little bit not well explained in or assessed in the questionnaire, this kind. And we had this discussion with other neurosurgeon.
Also helpful before surgery, it's to decide all together. So experts are agreed to say that interdisciplinary consultations or meetings, not necessarily consultations, but meetings with the PMR physician, surgeons, and also with the patient. We need to discuss all together. And the aim of that is to decide a technique for sure, but also to find a formal agreement with the patient to be sure that we have the same goal. Now we talk about surgical treatment, sorry. When patients have a fully correctable deformation, experts first recommend procedure involving tendons. In the case of a patient able to walk, we can propose neurotomy only, without other procedures. But for no tendon tenotomy, no tendon or muscle lengthening when a patient have a fully correctable deformation. But we couldn't find a consensus regarding tendon transfer and alcoholization. So we are going to answer the question together. And also we couldn't find any consensus in the surgical treatment to propose to patients not able to walk. Okay, so I hope it works now. Well, it's a yes or no, so we can do Alberto techniques on this one. In the case of a patient able to walk with fully correctable equinevarus deformity, can a surgical procedure combining neurotomy and tendon transfer be proposed in some cases? I mean, in a patient not able to walk. Able to walk, sorry. Not able to walk, it's the one after. So patient able to walk, can we do surgical procedure combining neurotomy and tendon transfer?
And again, this question means if you do a block, it's correct. Is the question if you do a block, a motor nerve block, the deformity is correctable, or just with your hand you can correct it?
Correct it with your hands.
Okay.
Oh, but I didn't. Okay, so 40% are saying yes. If someone has any questions or any... Next one. So, in the case of a patient not able to walk, presenting a totally correctable equinevarus foot deformation, is it the previous one? No? Okay. So patient not able to walk, totally correctable equinevarus foot deformity. Can we propose surgical procedure combining?
So for this question, you can choose more than one. You can put 1, 2, 3, 4, 1, 4. Or you can select several questions. Is there any remark on the question? That's okay? We can go? That's perfect? Okay. Yes, we are limited at 2 answers, Salim. We were limited to 2 answers, Salim. So, okay, I think that's wrong because some people have been limited with 2 answers, no?
Yeah.
Have the hand? Okay, so we are going to make response per response just to have an idea. So, neurotomy, who is agree with neurotomy? Okay, huge. Tendon and transmuscular lengthening? Okay, perfect. Okay. Tenotomy? Yes. Sorry, just a minute. Who is not surgeon here? Who has not the box? Just have your hand, because you are not surgeon or physician. Okay. And tendon transfer? Okay, that's perfect. So. Next.
And last question, would you recommend muscle alkalization to treat correctable equinevarus foot deformity as an alternative treatment if botulinum toxin injection and neurotomy are contraindicated?
Is there any question about this question? Okay. So you can respond. Sorry, the timer. Yes,
Sorry.
that's correct. Okay.
You can answer now.
Okay, so that's not really a consensus, and we have to. Is there any remark, discussion about that? Maybe yes.
The following question, if I remember well, is dedicated to nerve alkalization. So here I vote yes, but I did forget the following question. I would have voted no if you say nerve alkalization. Right? So, okay, if nerve alkalization is possible, no muscle alkalization.
That's why. So, the next one is nerve. Okay. Okay. That's possible to go back for this question, just to, not this one, that one, just to make the vote another time.
No, but maybe we can do...
With the hand,
like
okay, if you prefer. So, who would respond yes to this question? Up your hand. Muscle alkalization. Okay, it's about 1, 2, 3, 4, 5. Okay, so it's, sorry, 22. Okay, that's a few. And the next question, and after we will have a discussion.
Yeah, so this one is exactly the same, but nerve alkalization.
Nerve alkalization. So we try the delphi, the media vote, come on. Yeah, it works.
who has the past year a patient who is not recommended for toxin and neurotomy. So
It's a way of thinking.
in a way, it's a non-question, you know.
Thank you, Thierry. You are really my friend. I remember that he helped me to write the questionnaire at the beginning of the story.
Okay, so 35 years.
The monies, I mean, of course. So you.
Maybe not contraindicated, but perhaps not if it's, instead of saying contraindicated, perhaps if it's unavailable or not an option.
Okay, okay. Okay, so now maybe we need to have a discussion between muscle alcoholization and nerve alcoholization. Is there some people who practice, muscle alcoholization? Do you have any, Philippe peut-être, alcoolisation musculaire? Oui. Yeah, comment? Yes. Et c'est ton indication? Philippe said that when botulinum toxin is impossible because it's contraindicated, for example, or not possible to inject. When neurotomy is not so easy to perform because there is strong antagonist, and the tenotomy can't be performed because it's strong antagonist, and so you are a little bit, in no way. So you can inject some alcohol in the muscle. And it works, and it's true. We do that sometimes. So for us, it's a real alternative.
I think depending on the acid structure and volume, you maybe need to inject high volume of alcohol. So, you didn't see any necrosis after these injections? Maybe sometimes it is repeated injections also. What about necrosis after alcohol injection?
We never had some necrosis of the muscle after injection. Nécrose musculaire. Even if there were. Philippe said that he had never had any issues after alcoholization of the muscle, such as, infectious upset or this kind of. Obviously, the muscle is a little bit destroyed, but it's what we wanted to just to do. It's like a tenotomy or something like this. So it's possible to use it in our point of view. Okay, no consensus. And for the nerve? For the equinevarus foot, which nerve? Which nerve do you inject for equinevarus foot? For me, that's not so easy, because with alcohol, there is no specific motor nerve blocks, and sometimes it creates a lot of pain. So for equinevarus foot, that's not alcoholization of the nerve. It's not really for me. Sometimes I go, but that's not really very safe, except the gastrocnemius, maybe.
You have one comparative study from Kirasley, phenol versus bone, and with 30% of neuropathic pain when you target the tibial nerve. But the solution is to perform selective nerve block with alcohol, the same technique as with anesthetics, and it works. But
thank you. We can go through.
Okay, so now if we look at partially uncorrectable deformities, so the experts were agreed to say that the first surgery has to target tendons to exploit functioning muscles. But then for the neurotomy only, there is no consensus for that. So we are going to answer the question. And we can combine neurotomy, tendon lengthening, transfer tenotomy on different muscles tendons and nerves on the same limb. That was a consensus.
Oui?
You need to ask.
A comment? Okay, is it? Can a sole neurotomy can be proposed in this question? It depends from the extent of the partially correctable. If it's -5 degrees echinus, the question will be different instead of 20 degrees echinus.
Yes, of course. The idea is for the guidance. If it's even if you have some restriction, it's a solution for you. So you say yes here. Not for all the cases, but in specific case you do it.
Yes, but if we answer yes, someone who will read the paper will understand that when you have an uncorrectable foot, you can perform neurotomy alone, which is not the case.
But during the writing of the paper, it's we have some qualitative response, and you have to deal with that and to explain that yes, in certain cases, in most of cases or certain cases, and mainly in this. And this is a discussion we will have when we are going to write the paper.
Clinically or after block?
I think you have to think generally. Is it one of your tool in your box? Even before you make the assessment you want to perform. I think the question is when you have a mixed deformity of the equinevarus foot, is it possible to perform only a neurotomy? Maybe because you have to make first of all the neurotomy and after to see how it works. Maybe because you have made an assessment that maybe the spasticity, the limitation of the range of motion because of spasticity is huge and not the contracture. I don't know. But in your history, do you have made only sole neurotomy in a mixed deformity of the equinevarus foot? There is some people here who said no. So that's why, for me, it's a question. Yes, Philippe Rigoire, neurosurgeon.
Yes, François. I really think we need to clarify the questions before just taking the vote. For me, François, I'm just fighting against the young, not the young, but the neurosurgical community, because they don't have the idea to collaborate with orthopedic surgeon. They think that neurotomy can solve anything because they are restricted in their vision. And for example, in October, we will do a course for the young neurosurgeon. And I was expecting that at this question, everybody would answer no, saying don't do neurotomy and only when you got a partial correction of a deformity, because you need also the expertise of the neuro-orthopedic world and the tendon lengthening, So I think that you can take this question in two different ways. And for me, if I want to convince the young neurosurgeon to work together with orthopedic surgeon and not to have the vision and only of the nerve, I need to say a sole neurotomy, of course, is part of my arsenal, but this is not the answer for a patient who has got a mixed deformity, including retractions.
I would feel more comfortable if the end of the question would be, should a sole neurotomy be recommended? Point. And so the question is more clear in this way, to my opinion. So, of course, you can every time do one thing and another thing after, but I agree with our colleagues.
Any other reaction? Do you follow Thierry? Franco, do you have any idea of this?
I agree that this is a general question, and I think that it's very important to say, if you have overactivity and retraction, why you have to perform just neurotomy? This is a key point. Then in some cases I agree that maybe that if you look 100 patients you will have 3 cases where, but generally speaking, when you have both, why you have to perform just neurotomy and to maintain retraction?
So Yann Magulet, just behind you.
From an exam theory perspective, as soon as you have any question that says in some cases, you have to put yes, because the chance of you being wrong by putting no There's always one person. So if you're going to pass this exam, you have to put yes. Not, even if you completely disagree with it, you have to put yes.
So maybe it's not really the question, but you have to make this discussion, you know. So why? Is anyone can answer to Franco Molteni? When you have a mixed deformity, why do you want to perform only neurotomy? Is someone wants to respond to this question? Or sometimes, in which case, Stefano Carda.
Because sometimes you don't need to correct completely the foot, for example. You need some equinus to stabilize. Sometimes you want to see the effect of removing just spasticity and see if after 6 months or 1 year, just he gains 10 degrees or 5 degrees and it's okay, you don't need another procedure. It's a possibility.
This is another story again, because means that is not a real fixed contracture, and then means that the reduction of passive function is related to overactivity that you are unable to detect before surgical procedure.
Yes, but in our experience, when we treat first the tendon by a lengthening, you change the overactivity and the spasticity. And we prefer to begin treating the contracture than the spasticity in our community. So if you want to correct partially something, we prefer to go before to the orthopedic, the tendon, the contractor, because after the surgery, you will change the shape of the motricity, and you have botulinum toxin if you want to treat the spasticity. So for me, it's not in this sense, like you said, Stefano. We prefer in our community to treat before the tendon. Philippe?
Et je pense qu'on a souvent une confusion parce qu'on pense souvent à l'équin. Et il faut qu'on soit bien d'accord que l'équin, le comportement des gastrocnémiens et du solaire est souvent différent. On a souvent un solaire hypertonique et un gastrocnémien rétracté. Donc je pense que c'est important de bien distinguer, avoir une approche bien muscle par muscle et non pas déformation par déformation. Et je pense que sinon c'est une source de confusion.
Philippe said that there is difference between gastrocnemius and soleus, and we have to think by muscle and not only by deformity, because the contracture is often for the gastrocnemius and very often for biarticular or multiarticular muscles. In reality, it's the same way for the biceps and biceps and that stuff. And the spasticity is more for monoarticular muscles like soleus and brachialis. So, is there any reaction about this? Are you agree with this? Yes. Caroline Leclerc from Paris.
Well, François, as you know, I don't deal with the lower limb, but I do think this is a very important question, and it's as important for the lower and for the upper limb. So I think that this question is dangerous, and I agree with our neurosurgeon colleague here. We have a number of people who think that, by dealing with nerves, they can solve a lot of orthopedic problems, and it depends what you want to convey in your article. If you want to make things simple and clear, I would remove this question, or I would make it different. Because really we need everybody to understand that there is many causes to the deformity, and we need to deal with all the causes of the deformity.
I agree. I think we have a discussion as if we were in consultation. We need a global question with a global answer, as it's a delphi. So.
François, I'm sorry to insist, but it's exactly the question, I think. It's the responsibility we want to take by providing guidance. And here, clearly, I can see for some cases a sole neurotomy respecting the deformity on some patients and assessing the different components in the soleus between the overactivity and the retractions. The thing is, if we provide yes to this question to the neurosurgical community of the people who don't believe that you should do any tendinous act on the surgical intervention on those guys, all the surgeons, they will continue to do neurotomy and only for all mixed equinus foot, taking your recommendation as the guidelines and what will protect them. So it's just a matter of what we want to achieve.
Thank you, Philippe. Maybe it's a dimension we have to take into account. Our guidance must be very simple and in the general and things that we'll be sure to do every time, or if we have some restriction. And in this case, the restriction is too complex, and so maybe we have to delete this question.
But I think in the quality of the paper you're going to provide, then you can come from macro zoom to micro zoom, and then go into the details and the restrictions.
Okay, you are going to help me for that?
Yeah, with pleasure.
Thank you. Thank you. Right. Albert.
Sorry to be a voice of the nay here, but this is not the right place or the right way to do delphi process, because we're now discussing if the question is the right question. And so when you get to that point, then you lose the sense, because you already have a process. You have a question. If the question is not correct or it's not clear enough, you answer no, and you move. And so that way is the way you get the delphi, because you have to eliminate things. That's what the process is all about. It's which things can we agree upon, which things we do not agree. So if I see a lot of disagreement, you just vote no. And that takes care of that.
Okay?
And we need to move on, so it's... Okay, good.
Thank you. It helps me a lot.
No, so let's vote for this one.
Okay.
Okay.
Thank you. Okay, but so we had already the discussions. we can go through for the next question, because it left only 10 minutes for the rest of them.
Okay, so for surgical treatment, experts are agreed to say that tendon and muscle lengthening and tenotomy can be done using open surgery approach, but also percutaneous procedures with needles. And very interesting thing is PMR are also able to perform percutaneous single tenotomy procedures just if they received a specific training for that. And that was a consensus. What about the delay between central nervous system damage and muscle transfer? We couldn't find any consensus on that. So we're going to vote. So what should be the delay between central nervous system damage and the decision to perform a muscle transfer?
What do you mean by muscle transfer? Active or passive, like tenosynovitis?
Yes, that's a good question. I think it was active in our mind.
Okay, you can vote now.
Normally there is some music, but we don't have. Maybe Marjorie can sing.
No.
Or dance.
Okay, so 27% think the delay doesn't matter. It depends on patient situation.
So
and
obviously that's no consensus on these questions.
Yeah.
Can you go through,
Next
Marjorie,
one.
please?
What about bone and joint procedures? So we should first recommend soft tissue surgery more than bone surgery or joint surgery, even when there is deformations. Concerning arthrodesis, procedure, experts think they are decreasing. The number of arthrodesis are decreasing over time. But the experts couldn't find any consensus concerning the good indication for a double arthrodesis.
So double arthrodesis it's subtalar and chopard, and not tibiotalar.
Yeah,
Okay, it's not triple arthrodesis. Okay, because there's some difference between country.
So from your perspective, what is or are the indications for double arthrodesis? You can vote. Okay, so most of the people here think it's better for osteoarthritis with pain, also unstable ankle, but no consensus. Does anyone have a question, a remark, something?
Okay, we're going to deal with this and to compare with that.
It's not a consensus, but most of the time experts were saying that bilateral and stage deformities, we couldn't decide if we should do them in one time or in two different surgeries. It globally depends on patient situation and also his environment. What about the risk after surgery, of the surgery? Concerning urinary bacteria and documented infection, and also for active smoker and arterial insufficiency, all experts were agreed that there is no contraindication of bacteria, urinary tract infection, active smoker, or arterial insufficiency for tendon and nerves procedures. But we couldn't find any consensus for arthrodesis procedures. So we are going to vote, but this one is special because we ask only the surgeons to answer to these questions. Maybe you want to explain? Because
yes.
The results were very heterogeneous, so we try to focus a bit more on surgeons. So as a surgeon, would you perform bony surgery on patients with a documented urinary tract infection? Or you can answer, I'm not a surgeon. Okay.
Okay, we are going to put all the surgeons in one small room.
And close the door.
Close the door and...
What you're missing here is half of the surgeons are orthopedic, the other half...
Neurosurgeon. There is some plastic surgeons also, maybe. I don't know, I think it's... Next one.
So same question for the surgeons, but for arterial insufficiency. Would you do surgery on bony surgery on patient with arterial insufficiency? On peut les voir en direct.
Okay. I change, like this a little bit. Okay.
But it's half-half. Okay.
Yeah. That's normal, I think.
What about after surgery? So after surgery, we are going to talk a bit more about post-surgical immobilization because experts were not agreed at all. So we are going to talk a bit on the elbow session this afternoon. For post-surgical care, we try to organize that as soon as possible. When patient is in consultation already, is going to have an appointment with a social worker to try to see if he can go home or go in rehab. So that's a consensus. Another thing is PMR can, in contact with the surgeon, be the medical doctor who remove the cost after surgery. He's also the one who is going to see the patient until the third month after surgery, and he can follow the patient after post-surgery follow-up. For botulinum toxin injection after surgery, there is also a consensus. So for the overactive muscle around the ankle or the foot which has been operated, we can use botulinum toxin to treat overactive muscles newly identified. So if after surgery there is new muscle overactive, we can treat them with botulinum toxin, but also we can use botulinum toxin to treat other parts of the body to target new objectives. Once the foot is not an objective anymore, we can target the elbow, the shoulder. Thank you.
So obviously we are going maybe to discuss this this afternoon. It's the representativity of the panel who respond to the questionnaire. We have some experts from all over the world. That's not really the problem, but the difference between PMR, orthopedic surgeon, and that stuff is obviously a limitation of our results. But okay, we're going to see that. As we are a little bit late, we are going to ask it's Rajiv now.
Would you want lunch and then we do it after?
You are hungry. Is that possible to make lunch now? We have to. That's okay. Yes, Laurie said we need to have lunch. Yes, a delphi question. I said it will be yes. I think if it's no. So yes, the device. Can you put it on the table over there? Just don't keep the device in your pocket, please.
finalement.